All right, thank you everyone for your patience. We're going to begin our event now. Medical Herstory is so excited to present The Pleasure Gap, Demystifying Sex Ed as part 3 of our storytelling series. So although we're meeting from around the world today, I would like to acknowledge that I personally reside on Treaty 6 territory in the Métis Nation of Alberta, Region 4, as part of the Métis People's Homeland. Amiskwaciwâskahigun, or what is predominantly known as Edmonton, Alberta, Canada, is the traditional and ancestral territory for many First Nations peoples, including the Niheau, the Dene, Anishinaabe, Saulteaux, Nakota Iska, Nakota Sioux, and the Niitsitapi. So with deep respect and sincerity, I express my gratitude towards the Indigenous ancestors who have acted for centuries as caretakers to this land. As the daughter of refugees who were displaced from their own homelands, I acknowledge both my privilege and my responsibility as a non-Indigenous healthcare provider. I understand that the mere act of acknowledgement will not make up for the ongoing consequences that colonization, white supremacy, and oppression play within the healthcare system. So with that being said, I would like to call upon my colleagues and friends here to join me in ongoing efforts towards reconciliation by committing to learn and grow within a manner that will honor our diverse communities and peoples, no matter where we are from and no matter the settings in which we hold space. Something that I'm doing for my own relearning right now is reading Indigenous Rights, a guide to First Nations, Métis, and Inuit issues in Canada by local Métis author Chelsea Bowell. Below, Medical Herstory has also linked to Native Land, an interactive resource developed by a Canadian nonprofit in which participants can learn more about Indigenous territories, lands, and ways of life across the world. I'm going to pass this off now to our founder, Tori, so she can tell everybody about what Medical Herstory is.
Hi, everyone. Thank you so much for being here with us today. So Medical Herstory is an award-winning youth-led not-for-profit on a mission to eliminate sexism, shame, and stigma from health experiences. We advance gender health equity through our main programs of medical education, patient advocacy, and undoing social stigma. We have a range of events and over 100 volunteers across 7 countries, and we hold events like this to really raise awareness of important issues and break down taboos, as well as hosting workshops for patients on how to access healthcare and healthcare providers about how to break down bias, as well as, if you've been to our website, sharing first-person narratives about a range of physical, mental, and sexual health experiences. So definitely be sure to check us out, and you can follow us at Medical Herstory on all social media to stay up to date if you enjoyed today's event and want to come to more in the future. Thanks so much.
Thanks so much, Tori. So as I said, this event is the 3rd installment in our storytelling series. This informative panel hopes to shed some light on the importance of sexual health education, and we want to aid in breaking down some structural barriers that currently exist surrounding sexual health to make sure that every individual feels safe and empowered to seek the healthcare resources that they need. If you'd like to review this event later on, after today, it will be posted on the Medical Herstory YouTube page that will tag all of our wonderful speakers today, where you can also check out past events as well. Today, we're partnering with Oxfam, a global charity organization focused on fighting inequality and patriarchy to end poverty and injustice through empowerment, embracing inclusiveness, and demanding accountability. My name is Victoria, and I feel really honored today to be hosting today's panel event. I've been a registered nurse for 4 years, and I've spent most of my career as a labor and delivery nurse. But for over a year, I've also worked as a public health nurse at Edmonton's Birth Control Center. We're a drop-in clinic that provides sexual and reproductive health care, including contraception, STI testing and treatment, as well as pelvic healthcare for people primarily with female reproductive organs and who also face different barriers to accessing healthcare. I have a specific interest in understanding the different things that influence access to healthcare for marginalized and vulnerable populations, including structural barriers, which is why I'm currently working on a certificate in women's health through the Faculty of Women's and Gender Studies through Athabasca University. But while you're seeing just my face today, there are so many people behind the scenes that have worked to develop this event. So I'd love to give a huge shout out to our events team and also our media team. I've worked really incredibly hard to make this event today happen. We're just going to quickly go over some Zoom rules and housekeeping issues. So if you haven't done so already, please make sure that you mute yourself unless you are actually speaking. There will be an open Q&A at the very end where you can either use the chat or you can speak directly through the microphone. As we've said, this event is being recorded. If you feel comfortable, we always love to see your faces. So feel free to open up the camera. And use the chat to participate or ask any questions throughout the entire time. There will be an open Q&A, and we'll be recording and looking at those questions that come up throughout the event as well. We do have 2 active listeners today. One's Daria and the other is Sophie. They will be keeping an eye out for any questions or concerns with Zoom throughout the event. Closed captions are also available. You can enable them for your side. They'll also be available for a recording as well. And as always, please be respectful and inclusive with your language and your behavior. So that being said, we're just going to do a quick content warning. Topics of today's discussion does include sexism, racism, ableism, fat phobia, medical trauma, mental health, and other sensitive subjects. Medical Herstory does recognize the challenges of today's discussion. We're extremely grateful for our speakers to share their experiences and their knowledge. Please do what you need to do to take care of yourself, practice self-care, and take breaks if you do need to. So we're going to move on to our first question, which is basically just getting all of our speakers to introduce themselves, as well as just sharing their story of how their journey in advocacy and sexual health began. So we're going to start off with Goody, if you wouldn't mind.
Okie dokie, no problem. Well, my name is Goody Howard, MSW, MPH. I always say the degrees because I'm still paying for them. My pronouns are she, her, and boss, and I don't code switch and I cuss a little bit. I am a sexuality educator, consultant, and speaker. And essentially, I have 3 business models. I do pleasure development, which is the fun stuff. I sell pleasure tools. I teach sexual skill building workshops, and I sell t-shirts that I call goody gear that are sex positive and kind of keep the conversation going when you wear them in the street. I do professional development, so you can find me on college campuses, in companies, and in communities, walking the walk that DE&I talks around sexuality, gender, and equity. And I also do pleasure professional development. So I am a business coach to human sexuality professionals because mainstream business coaches won't touch us. They don't know what to do with us. They don't understand the challenges and censorship that exists in our industry specifically for us. And so I help other human sexuality professionals sort of not pour from an empty cup, but start to pour from their overflow.
Hey, thank you so much, Goody. It's a really important aspect of sexual health to talk about what makes you feel good as well. And I think it's great that this is the work that you're doing to share in everything that involves sexual health, including pleasure. Thank you. Lorraine, would you like to introduce yourself next?
Yes. So hi, my name is Lorraine. I create content primarily on YouTube and Instagram under the nickname of Lorraine HD, which kind of shows how long ago I have started this content creation, because HD is definitely not the sort of peak that speaks for quality and content. But anyhow, embracing it. I'm a certified holistic sex educator based between Berlin and Paris. I teach comprehensive sex education in French schools, all the way from elementary schools to high schools. And I also teach or train professionals who work with youth to approach conversations around sexuality in an inclusive, shame-free, engaging, and pedagogical way. And my journey advocating for sexual health began, like probably many of us, with a very personal experience getting diagnosed with HSV2, which is herpes type 2 on my genital area in 2013. And it wasn't my first experience with STIs, but it definitely was my first experience with incurable STIs. So that felt like a little bit of double dipping in the pool of shame that I thought I was in. And so I spent a few years really learning how to take care of my body from a physical standpoint of like treating my physical symptoms, but really disregarding all the emotional symptoms that come with an STI diagnosis, let alone an incurable STI diagnosis. And so those emotional symptoms were kind of, withdrawing from the dating scene or thinking no one would ever love me or want to date me if they knew of the condition that I had. And I didn't even Google it for 2 years. So that's how shut down I was from my diagnosis until I realized that, not embracing my diagnosis was kind of leaving that as an open wound, and anyone who would even delicately, like gently touch it, it would still hurt because it was open. So yeah, that's when I started, did a 180 from not talking about it at all to telling the entire internet, the world, and their mothers. So, and here I am.
Thank you so much for sharing, Laureen. I know that you were not alone. I know so many people that I come into contact with at the clinic that have the same kind of or similar stories to you with their HSV2 diagnosis. And it's really great that you feel comfortable now sharing your story and what you did to kind of engage with that and manage that chronic diagnosis and not letting it limit your self-worth and your experiences in life. And it's great to hear that you're doing the sexual education. That's such an important part that's really not talked about. I know at least in North America for sure. And so it's interesting to hear from that European side as well. James, would you please introduce yourself?
Yes, hi, I'm James. My pronouns are they, she. I am coming to you today from the stolen land of the Lenni Lenape people, also known as New York City. And I work in the States with Planned Parenthood. Most recently, I had syphilis like last year and I made it my whole personality on the internet because why not? And I realized that there were a lot of people that had no idea what was going on with STIs. And I suppose I knew that because I didn't know anything about STIs or sex education. I grew up in Florida, which is an unfortunate place where they teach abstinence only education, and that completely failed me. And so as I started hooking up with half of New York City, I realized there was a lot of people that didn't really know anything about sex ed either. And so I decided I would overshare on the internet and hope for the best. And I think it's turned out pretty okay for the most part. And so I'm really proud to be in company with everyone else who's doing such similar, fantastic work today. And that's kind of the half of my sex education world. And the other half is that I develop anti-sexual harassment programs at different theaters and different corporations across the country as a survivor of sexual violence. And to me, it's impossible to silo one into the other. They are very much a fluid experience. And sexuality is something that, of course, I feel very passionately about as a queer person in terms of both gender and sexuality. So I feel like it's all connected, and I'm excited to be exploring more about those topics today with everyone. So that's a little bit about me.
James, thank you so much for sharing. I think in this age, like oversharing on the internet is exactly what we need, because that's how else are you going to break down barriers other than to share your story and not make it so scary. So thank you for being brave enough to do that and letting everybody else know that it's just okay. I think the more that we talk about it, especially STIs, the better our education and the better our kind of awareness is going to be about the topic. So thank you. And Jasmine, please introduce yourself.
I don't know if it was a good idea or a bad idea to be the last person sharing, because I'm like, after everyone sharing, I'm like, my nerves are growing bigger and bigger. But my name is Jasmine. I am a sex positive advocate based in Kuala Lumpur, Malaysia, which is on the other side of the world. So it's really cool to talk about my experiences here in Malaysia. And I also see the nerves. I also founded Just Explains, which is essentially a safe and empowering sex positive space to unlearn all that we've been taught about pleasure in our bodies. It's a space to ask questions, be curious, and share your experience, or just be open to listening to experiences and hopefully be empowered to explore and speak our truth. So a little bit of background to who I am. I grew up in the part of Malaysia which has the highest rate of teenage pregnancy. And so when I was in high school, it's really normal for us to listen to girls leaving school at such a young age because, they get pregnant. And, that's such a normal thing. You're like, oh yeah, she left school because she got pregnant. And then now looking back as an adult, I realized that's actually not normal. And it shouldn't be like that. And even when I was younger, I realized that, I wanted to talk about sex education, but nobody wanted to talk about me. But then when you turn on the TV, it's all on MTV. You see butt shaking, boobs jiggling, hanging everywhere. But when I ask my parents or when I ask adults and my teachers, they get really tight-lipped about everything. And so, naturally I would turn to the internet. And fortunately, back in like the mid 2000s, 2006 or so, we do have sex educators, right? YouTube was there at that time. We do have sex educators, and I learned so much. But the issue with that is that a lot of these sex educators are actually from the US, or they're from the UK, so they're from the Western part of the world, which is great in terms of learning basic stuff about our bodies. But at the same time, I didn't feel connected to a lot of the narrative that was being shared, because they didn't understand what my culture is. They don't look like me. And that was, I think for me, like, it's very confusing, because I can't just walk into the pharmacy and get a condom. It's unheard of in a country like Malaysia. And so when I was now as an adult, I kind of, the whole reason why I started Just Explains, besides that, is the fact that I actually was so intertwined with my work. My identity was my work. I wanted to have a passion project. And so my passion project was sex education. I was really passionate in this as a child. And I then created a sex positive Instagram page that kind of morphed into, so this Just Explain was created in 2019 and morphed into not just an Instagram page. COVID happened, and then I was invited to different talks and workshops, and then I started creating my own platform, my own workshops, because Malaysia needs more of this. So I started creating my own platform, my own events, my own mingles, and more people start coming in and join me. So there's always this question of like, is Malaysia a conservative country in Asia, Muslim state? Are we ready to have this sort of conversation on sex education and on sex positivity? And the thing is, we're really, really hungry for all this conversation, but there is just no place to have this. So this is why I started Just Explains, and I wanted to put a face, because a lot of times there's a lot of fear that there's going to be backlash. But the thing is, when you have a sense of purpose, it's so much stronger than all this backlash, because you already know, like, hey, this is my purpose and this is what I'm going to do. So anyway, that's me in a nutshell. Thank you so much for having me.
Thanks so much, Jasmine. I think even just listening to you talk, I think it speaks to me a lot. I'm mixed race Vietnamese Romanian, so I think a lot of my identity comes from that kind of taboo topics in like Asian culture, where you don't really talk about sexual health or sexual education. So a lot of it has been like, as I'm growing up, learning about all these things. So it's great that it's something that speaks to you as well, like that passion project and recognizing something that is in your identity. And I know that a lot of sexual health and mainstream media is very Western centered. So it's great that you bring that really important perspective as well, that often gets left out of the conversation, being more from the Asian kind of perspective as well, to kind of teach people and tell people about it. And yeah, that bravery that you have to kind of put a face to the name because of how important it is. That's really important. Thank you very much for being here today. Thank you, everyone, for your introductions. I'm so excited for this panel. Let's move on to our next question. This one is going to be an open one for everyone, but maybe I'll start off with Laureen. This one is, what are some common misconceptions or stigmas surrounding sexual health that have upheld barriers to accessing or improving the field? What steps need to be taken in order to eliminate those barriers?
Yeah, I feel like we could spend, 5 hours. I don't know how many days actually discussing this one. There's so many misconceptions that are rooted in stigma. For STI specifically, a prevalent one is that if you don't have symptoms, it means that you're not, you don't have any STIs. But as we know, STIs in the majority of cases, about 80% of cases, don't show symptoms. So there is this prevalence of thinking, well, if I had something, I would know, and then I would get checked, and not incorporate STI test as a routine health checkup that people do, at least once a year, but it can vary depending on people's sexual activity and if they change or have a lot of partners. The other misconception is that if people had an STI, well, they would bring it up naturally, because if if you had a cold, you would tell people, oh no, let me not hug you because I have a cold. Well, guess what? Colds and STIs are not created equal in society or in people's eyes in the conversation that we have about them. That people who have STIs are somehow that you can tell if someone had an STI, that having an STI is linked to a behavior. And I think there is, like in many instances, there is this circle which is true for one half of the circle, and people just want to close it up. So of course, if you have unprotected sex, if you have multiple partners, this increases the likelihood that you would contract an STI. But just because you have an STI, it doesn't mean that you have had unprotected sex or that you have had multiple partners, and so on and so forth. So I think this idea of, well, if this person has an STI, it means that somehow they have done something to contract an STI, because if you are careful, you don't end up contracting an STI, as if, STIs were not a part of sexuality, even if you have protected sex, even if you, get tested for STIs because you have specific windows for specific viruses or bacteria, your tests can have unreliable results. And it takes an incredible amount of education to know all of this and to monitor your steps as, you're also living your sexual life on the side in with some lightheartedness, thank God, because if we had to keep that at the forefront, it would also take away a little bit of the spontaneity or the enjoyment that we have with sexuality. But for me, another misconception, and then I'll pass the mic, is exactly that talking about sexual health is somehow takes away from the connection that you have with someone, or that it makes the moment less magic, or that it takes away from the spontaneity of the connection between you and your partner, when in fact talking about sexual health really, one, shows that you are someone who puts safety in the forefront, and that you value sharing, information about yourself, and also receiving information about someone else, your partners. So all of those misconceptions, I think, are things that uphold barriers. And I think, as with a lot of things in sexual health, more conversation, better representation also of what it looks like to incorporate safe sex, and conversations about, STI tests, but not just STIs, also, preferred positions, or do you have pain when, if I do this, is this okay? Does this feel better? Does this feel, just better representation of what it looks like, what intimacy looks like when it also embraces safety, and not just, fantasy and artificial spontaneity. I think that would go a long way in, I don't know if eliminating, but definitely alleviating those barriers.
Anybody is welcome to jump in if they would like to talk as well.
I was gonna say that when I see the, in the field, right, as an educator, as a sexuality educator, the conversation, when people hear sexual health, they hear sex, they don't hear the health. When they hear sex education, they see sex, they don't see the education, right? And I think the stigma in and of itself, the world is a super sexualized place, but it's not a sexually educated place. And so I think there's a big piece of education missing. I think the conversation around pleasure, the global conversation around pleasure, is penis shaped, and it's cisgender heterosexual penis shaped, not just penis shaped, to be clear. And so I think we get lost in the sauce when it comes to ungendering the language that we use when we're talking about sexual health. When we're talking about, when I'm speaking, I say the genitals I'm talking about. I'm not going to say, oh, the woman's vulva or the man's penis. No, it's a vulva, it's a penis, because all women don't have vulvas and all men don't have penises, right? So I'm going to speak about the body parts in use. And I think there's a gap in the training. I also think there's a gap in the understanding of people that need training, because what happens is people think that they enjoy sex, or they enjoy talking about sex, or even learning about sex so they can do our jobs. And that is like going to a Michelin star restaurant and thinking because you ate that food, you can make that food, right? There's training missing. And even in that, the training looks a little, it's not accessible for the people that need it. It's not inclusive. It's not, I am not certified. I teach in organizations that certify sexuality professionals and educators, but I am not certified because the certifying bodies in America want me to pay to take classes that I teach. And here in America, it looks like, oh, I'm educated to this basically white standard, so I'm okay to teach other things. But I'm certifying other people. I'm faculty at universities to teach other sexuality educators. You see what I'm saying? So I think there's a gap, so many gaps. There's gaps in education, in training, in the understanding of what needs to happen, the perception of risk. I hate the word risk, right? Lorraine, you were talking about people thinking, oh, I'm gonna tell you something. Everyone that I know that's living with HIV acquired it from someone they loved and trusted, not from some random hookup. Listen, my people that are playing with fire are wearing oven mitts. You feel me? So they're not out here wilding, right? And going raw is the new promise ring. So our perception of risk looks very different, right? And so we don't have the media, and we are the media now, thanks to social media, right? But we don't have, I think there's gap in media as well. There's gap in portrayal. There's gap in understanding even biomedical interventions. People living with HIV don't get the same empathy as people living with cancer, right? That's a problem, I think, because people living with HIV, acquired HIV, condoms break, and marital vows get broken more than condoms do. So we're in a space where people are acting like Lorene was saying, that you out here, if you acquire an STI, oh, you did it to yourself, or you weren't being careful, or all, like, it's again that perception. And so there's no just one misconception. There are so many. And that's what I love about our work in our industry, because we're always all gonna have a job. It's expansive. It's something for everybody to do. You know what I'm saying? So it's definitely a gift and a curse. And I appreciate the question because it gives us a chance to highlight what misconceptions and accessible challenges we have in each aspect of what we do in the sexuality space.
I loved both of those answers, and I would love to just add on to them that I think that one of the huge misconceptions, just like Goody and Lorene were pointing out, is and hinting towards, is that sexual education, the scraps that we end up getting in the United States for sure are penetration centered. And I don't just mean like penetrative sex centered, meaning like the idea that not only like negativity around penetration, but like the idea that if you are taught sex ed, you're going to be permeated by something that's like impure, that you're going to be penetrated with something that you don't want, which automatically leads to so much shame around penetrative sex or any other kind of sex, because you get to name what sex means to you. If you feel like kissing is sex, kissing is sex. If you feel like penetration is sex, penetration is sex. Those definitions change because people's lived experiences change, and we're not, as a culture, great about holding space for the fluidity around these definitions and what people's emotional responses are to physical actions. And I think that having it be so penetration centered is exactly like what he was saying. It's a symptom of white supremacy. The only education that we're offered is through the lens of whiteness, of patriarchy, of racism, of anti-transness. I think something that I found most pervasive in the work with transgender people. So like, when I'm a trans person, and so when I go seek healthcare, it looks different for me than it might for a cisgender person. And I'm finding that a lot of the sex education is completely lacking for medical providers. Most people think that trans people who are going on hormone replacement therapy are infertile or that we're sterile. I mean, it's not the case at all. There are plenty of trans men with uteruses that are having healthy pregnancies whilst also taking testosterone. There are plenty of trans feminine people that may be on hormone replacement therapy that still have the capacity to aid in a pregnancy. There are still many, many people that are still, there's a lot of stigma, I think, around that to break as well, and like what the implications of endocrinology are on sex education is something that is sorely lacking. And I think it's because when you take any marginalized identity, and I would introduce the word whorephobia to this, in that historically people who have been sex workers have been marginalized from society, from everywhere. It's blurred out, but that big sign says sex work is work in big red letters. So, pretend that's there in my background, right? And what we find is that anybody who touches sex, anybody who doesn't fit this, cis white heterosexual capitalist hellscape patriarchy, if you don't fit into that, then you are an outcast, and therefore you don't deserve access to this very limited scope of education. And I think that whorephobia has really played a lot into this, because it's an easy one to attack anyone for, damned if you do, damned if you don't kind of thing. You're either too promiscuous or you're a prude. And I think I reject all of those things. And I feel like many people in this space would. And so I'm finding that the unlearning of whorephobia, the unlearning of the idea that sex automatically is anything moral to begin with at all, is something that we really have to grapple with as a culture, and not only as a medical profession, but as a society, and the way that we treat other people. I think about it as like queering the narrative of sex, because to queer means to go against the grain, or to go against the establishment, to do something differently, right? So like we can take that out of the gender and sexuality idea, and we can queer the idea of what sex actually is, to be something that is individualized, doesn't have moral judgment placed upon it, and doesn't have to be something that is taught to us by all-knowing people, but something that we learn from each other in community.
And echo all of that as well. Like that's why I love holding these spaces, like these spaces, community spaces, especially amongst like Malaysians, or just people living in Malaysia, whoever wants to come and to have this space, kind of have these conversations. Because again, in Malaysia, we don't have this conversation at all, because we're all too afraid or too shy to, worried of being penalized. What's really funny is that when people think of Malaysia, especially when outside of Malaysia think of Malaysia or Asian countries, they think that, and because we're a Muslim state, predominantly Muslim state, that we don't talk about sex at all. There is no sexuality references or whatever. We're not sexual community or society in Malaysia. But interestingly, we're really, really sexual, because you can open a normal magazine or a normal newspaper and you can see everybody talking about like how to be like sexual, but then in the context of marriage. Is always in the context of marriage, always in the context. I like what Goody said, that pleasure is penis shaped, because everything in the context of marriage is to please the husband. It's always like, do you want to be tighter? There's a medication for this. Do you want to be harder, longer? There are traditional medication for all of these things. And that's really problematic, because what happens is that, and I talked to doctor, I just talked to this doctor the other day, that all this like traditional medication to like harden the penis or like whatever, or tighten the vagina, over the vagina or whatever, it's they all end up in the ER at the end of the day, because they're not certified, like medically certified. But then all this, everybody else just follows because it's traditional method. This is how you do it. And I want to please my wife, I want to please my husband. Mostly I want to please my husband. We need to do it. And because polygamy is a thing here too, the marrying multiple, having, more than having full wives because of the myth of Islam, there's always this fear, especially amongst women, like if you don't please your husband will walk away and find a younger wife, and you're gonna like miss out on all of that. And so there's this like fear, there's this talk about pleasure, there's this talk about sexuality, and like all these things, but it's very, very problematic, the narrative in this.
I could listen to all of you talk for hours. I think all of you just brought up so many things that I personally identify with, and professionally. Like, I think ultimately comes down to, it's like, as always, like sexual health is an intersectional feminist health issue. You brought up issues of harm reduction and safety, about polyamory. You talked about queering the sexual narrative, and like, who is sex for? Predominantly it's for the. It's, I think, very structured around a Western male gaze, and we need to like make it pleasurable, and we need to be talking about all these things and all the different facets that is involved with sexual health. And I love that you talked about how we often we sexualize everything to the point that we ignore all these different health topics, to the point that we don't talk about safety and we don't talk about pleasure or anything like that, and what it comes down to. So you all brought up so many good points about stigma and different different misconceptions that we need to really focus on challenging. Our next question, I'm going to specifically direct to James and Laureen. Throughout your time with this work, whether it's personally or professionally, what moments stood out to you as particularly challenging or beneficial to you as you experienced different aspects of the gender sexual healthcare system, whether it's with like clients or patients that you've worked with healthcare providers, with testing, treatment, or follow-up care? Anything that stood out to you?
James, do you want to start? Since I started the last question, I want to offer the mic.
Thank you. You are welcome to go first if you feel ready. And if not, I can.
Okay, yeah, I can speak about something that is very Germany focused. Basically, it is quite strange how Germany became the poster child at some point of dealing with COVID because they invested so much in prevention. So we were able to do COVID tests for free on a weekly basis, which meant that every time that we gathered with friends, we were asking everyone to get tested and to, send proof of a negative test. And that was very seamless. It was accessible in many ways. Yet with STIs, it is absolutely not a prevention approach that they are applying. So basically, even if you have insurance, unless you have symptoms, doctors will not test you. And if you insist, then they will still make you pay for it. Your insurance is not going to cover it. So this means that people are just making up symptoms, like going home, looking up on Google, what are the symptoms of gonorrhea, syphilis, HIV, and just going to their doctor, making up symptoms so that they would get a prescription for STI tests. And this reality is not even created equal for everyone, because when they define it as men who have sex with men, this is a population that obviously historically has been more impacted by STIs, especially when we talk about HIV. Everyone remembers, and is still, that community in the first place, but everyone still remembers the 80s and the AIDS crisis. And so if you say to your medical provider that you are a man and that you have sexual intercourses with men, then access to testing is almost seamless. But if you are a woman and you say you are heterosexual, even women who say they have sex with other women, that is a lot of a bumpier road, because again, it is centered around, historically what has impacted a community, which to my mind also sends a stigmatizing message that gay sex is dangerous, is risky, when in fact all types of sex comes with risk, and you can learn to mitigate those risks. And if people are asking to be tested, this is a good behavior that healthcare providers should reinforce, should encourage, and should deliver to, versus telling them, well, if you don't have symptoms, you don't need to be tested. Why? They absolutely know that you could still have an STI if you have no symptoms, but the healthcare system doesn't want to pay for it, because they know that, STIs are, we've known pandemic before COVID. It's just that we haven't called STIs a pandemic, but they are a pandemic, and it doesn't have to be scary. It doesn't have to be fearful. When you can diagnose them early on, you can treat them, you can talk about it. It's also a conversation with your healthcare provider, right? Very often it's patients who have to bring up, I want to be tested for STI, versus it's a a question that is asked even from your GP. How are you feeling sexually? Are you, what's your, sexual well-being right now? Are you happy? Are you fulfilled? When was your last test? We can give you a prescription for a test. And it's just kind of reinforcing that it's part of your overall wellness and well-being. So I think it's a two-way conversation that is not currently there. And I understand that doctors are not trained to talk about sexuality at all. So there is their own discomfort, which we all grew up with because it's a pretty erotophobic society that we grew up in. But also they are not trained to kind of go past these biases and by this discomfort. So yeah, just to kind of wrap it up, I think again, I could talk about so many different, barriers and challenges, but I'm trying to stay focused on STIs because this is where, people come to me the most for, and I have so many women who are in Germany who ask me, do you know of a clinic who will not make me come up with symptoms or who will do it for free? And it feels wrong to have to, come up with clinics that are on our side and that are somehow also appalled that this is the way that we have to do and take care of our health. And also, last thing, when you are pregnant, so if you are pregnant, then all the tests in the world are covered. And this is why a lot of people find out that they have cancer when they are pregnant, because for once they can just do all the tests and it's all covered by medical insurance. And to go back to the point that we were saying earlier with patriarchy and the role that is expected of female bodies, which is to carry life. When you carry life, then your health matters to us. But if you are just sexually active for your own enjoyment, then it comes at a cost. And this is, again, a cost that men and women, although I agree with you, Goody, I hate using those terms, but this is how providers see people and patients. If you're a woman, if you're a man, you're going to be treated differently regardless of how you identify. Yeah, it is just a very different experience when it shouldn't be.
Thank you so much for sharing all of that. I see the differences in our experiences from different countries, and yet I see the through line of like lack of care for human beings. And like, I think that is the main thing. It's like when I think about the monkeypox like epidemic that we had around New York City, and like just everybody, there was like a large reaction to that. If you're not aware, monkeypox is it's a strain of smallpox essentially that like had a lot of physical lesions, very painful, like very contagious. And there were large outbreaks specifically in New York in gay men who had sex with other men. And so then the prioritization of like our Center for Disease Control, the CDC, was to vaccinate only men who had sex with men, but you could only get an appointment in many places in LA and New York, which were the two places I was working during monkeypox. The qualifications, not dissimilarly, Lorene, to what you were saying, were that you had to have had an STI in the past 12 months, because that meant that you were considered higher, and to use Goody's word that we hate, risk, right? That was what the CDC was saying, which was so interesting because like, just because I had gonorrhea, 11 months ago, for instance, like make up an arbitrary number, doesn't mean that I am going to potentially be engaging with multiple partners now. And it also reinforced the idea that monkeypox was a sexually transmitted infection. It was not. It was something that you got through. Oh, is that giving me thumbs up? I love how that's my own screen is like helping me out here. Funny. So, I don't know where that came from. But point being that it started to get into this stigma where people thought that it was a sexually transmitted infection, and it's not. It was literally like it was a different viral strain that was transmitted through close human contact. Of course, of all the human behaviors we have, sex affords us the most human contact, I would argue, other than like maybe being on the one train at rush hour in New York City. But like, other than that, I found that the way that the government mismanaged that ended up creating so much stigma around queer people and around the way that men have sex with other men. And I found myself, like I'm a non-binary person who does have sex with a lot of men, who have sex with a lot of men. I have the unfortunate, distinct privilege of being attracted to men, which I think a lot of us share. And, we reckon with that as we do. And what I found is that there was a lot of like shame and a lot of stigma around having to disclose what your STI history was to a medical provider in order to get a monkeypox vaccine. And then there was also people who are in the healthcare worker system, for instance, like a nurse, say, who does have potentially close contact with a lot of people that couldn't get vaccinated because they didn't fit the qualifications. So it's just like, I think another example of how our healthcare system is not actually built for us, it's built for profit. And it's built to profit off of people who are at highest risk. And then the systems are built to make sure that you are at highest risk, right? And then I think just talking about risk for a second is, Goody, what you said earlier really like cracked my brain open in the best way, because I've really been reckoning with a lot of the I would say narrative in the specifically gay cis male community about protected sex versus unprotected sex, and what the moral stipulations are around that. Personally, I say that there are no moral stipulations, because that implies we all have equal access to contraceptives and education, and that we all have choice in every sexual situation, which, as many people will tell you, we do not, right? And I've been thinking a lot about how people try to shame other people for their choice there, and how for many people it's just not your business. Like, at the end of the day, right, it's like, if you're going to make a decision sexually, I think that the medical profession will place moral value on that. It's like, if I go in and I say that I've had X amount of unprotected encounters, and then a medical provider says, well, that's why you have this STI, and it's like, well, yes, but that's also something that we can treat. This is curable. All STIs are either treatable or manageable, and they're not all like curable. And I don't like the idea of a cure for them, because that implies that there's something wrong with having like chlamydia. There isn't. You know what I mean? You don't want it for a long time, and you want to get access to care. But like, the idea that, you know, whether you are using condoms or contraceptives or not defines what you deserve is something that we really have to push back against. And so I think about like the radical act of taking back your power in having unprotected sex, when people have survived the AIDS crisis and deserve to be able to have any sort of sexual situations they want to. People who are growing up today just get to decide what kind of sexual scenarios they want to consent to and what kinds of sex they want to have. And so I think that we're relieving ourselves of placing a moral obligation to define people's actions based off of some purity culture that's kind of got a grip on the back of our brain is something that we as a society are struggling with. But definitely, once you go into the seat and you're asking a provider for care, you have no idea what version of purity culture they are bringing into the room with you. And I think that often disadvantages marginalized communities the most. So there's a bunch of points in there, but I think overall it comes down to people are not treated as people. We are not being looked at as human beings that deserve access to care. And I think that when the government mismanages any sort of medical thing, as we have seen with any sort of medical crisis we've had over the past ever, I can't name one that's gone well, you know. I think that the underlying issue is that they don't care. And so we have to care for each other. And the only way we can do that is if we know more about what's going on.
Hey, do you want to quickly add something before we move on to our next question?
Yes, I was just going to say the gender differential is huge, in the sense that how Noreen said, you know, if you're pregnant, then you get access to all these tests. It's the same here in the States, but also when we talk about getting tested, and you have access to testing, people don't know to test your mouth, your genitals, and your anus, right? Because even if you're not having anal sex, you know, juices and berries get to flowing and things like that. You don't get an HIV test unless you ask, right? You shouldn't have to ask. It should be part of the panel. Talking about even on the intake forms. Part of what I do is evaluating people's intake forms. And they ask, you know, are you heterosexual? Are you this? I may have sex with women and may not identify as queer. I do, but I'm just saying, like, you say, I have sex with, and then you check that off instead of asking people what their labels are, because we then label people by what they decide their orientation is in that moment. And because it's fluid, it may not be that shit the same. I'm sorry. Cussing, sorry. It may not be that the same thing, right? And then you also have the last quick point I want to make is that even when we have these labels about who I'm sleeping with and all these other things, we say, oh, gay sex, or there's no such thing as gay sex. Everybody has a butthole, because what they're really saying is anal sex. And so if we think about anal sex in that way, if everybody has a butthole, I teach a dick riding class. It's called rideology. I teach people how to ride dick with their vagina, their anus, and how to caress two vulvas together, because it's not gay sex. We're talking about queer sex. It's queer because the people having it are queer, not the sexual act itself. And if we segmented our health intake and the way we respond to pandemics and epidemics and things based on the type of sex had as opposed to the people having the sex, our recording, our treatment, our responses would look very, very different.
Those are all very, very good points. I think it's very interesting because I think we all understand that like the medical and healthcare system is so flawed and it's so binary and so rigid in the language and the structure that it uses to base care and policy off of. Like sexual health is a public health thing. It affects everybody. It affects anybody who is having sex or wants to have sex or any kind of sexual activity. And I think it's like, Lorraine, it's really interesting that you bring up reproductive justice in Germany and the fact that the healthcare policy only cares about what testing you get if you're pregnant and have the capacity to reproduce and contribute to society and what is viewed as something that is useful in that society. And then just the way that monkeypox and mpox is kind of considered, that was James, the Alberta had a very similar kind of approach to recognizing mpox in the sense that we were running as an STI clinic, we were running the vaccinations for mpox, and only people who fit a certain structural criteria in which they identified as being gay or having sex with people with male reproductive organs were allowed or qualified to have the thing. So in the sake of time, we're just going to move on to the next question. We have 2 questions left, and I know we said we were going to try and stick to about an hour for the questions. So we're having a really good conversation, so we'll try and get through these 2 questions. The next one is open to everybody. We'll try and take the next 10 minutes for that, and then we'll have one more question that's specific to our two of our speakers. This question is kind of discussing, just talking about sex. So as we all know, discussing sexual health can bring up many feelings of anxiety, vulnerability, and shame. How do you navigate conversations to destigmatize sexual health topics in various settings, such as with sexual partners, friends, or healthcare providers? Or what can one do to normalize these conversations so that they feel more comfortable talking about sexual health with the different people in their lives?
So like for me personally, like I find that, but it takes a long time to just talk about it. So I find that talking about it more often, me personally talking to like friends and stuff, helps me to destigmatize a lot of things that I find really, really taboo. But then it doesn't happen just like that, because I think when I first started doing the work with Just Explains and my sex positive advocacy work, a lot of people were like, you're so comfortable talking about sex, but like you're Malaysian, you shouldn't be this comfortable. Did your parents always talk about this? And I'm always like, no, my parents never talked about this. The most sex education that I get when I was younger was my mom telling me not to be too close to boys because they will touch you inappropriately, or they will give, if you were too friendly to boys, then you're thrown away. And I remember my first catcall was even before I got my period. And I always say that was the mark of me being a woman, is when I first got my first catcall, as opposed to like my first period, which is really weird. So I think just talking about it openly and being comfortable with it is one way, but I also acknowledge that not everybody is comfortable about it. I was talking to a friend earlier. So prior to coming on this Zoom chat, I was actually talking to a friend who talked about how she had trauma, and that was very, very hard for her to talk about certain things, talk about her likes and dislikes. And, I think we were talking about also like listening to other people having conversations about this. So having these sort of conversations, these kind of discussion is really helpful, especially for me. If I am not comfortable talking about it, listening is another way.
I
Real
love
quick.
what you said. Oh, go ahead, Goody.
Sorry.
No, go ahead.
I was just gonna say I crack jokes all the time, and humor makes it kind of lowers the wall for people to learn. And there's a quote. It used to be attributed to Oscar Wilde that everything in the world is about sex except sex. Sex is about power. Oscar Wilde didn't say that, by the way, so we got to stop. He didn't say that, but it's true. And what I love to do is connect everything. I'm at a dinner party, I'm out here, we talking about something else, I'm gonna run it back and talk about how that is also connected to comprehensive sexuality education. I'll reframe it as, oh, that's life skills. Sexuality education is life skills. So I'll say, oh, that's this, this, and this. And I'm going to connect whatever you're talking about. I'm going to bring it on back to how it's connected to comprehensive sexuality education. And I'll call it life skills depending on the you know, the environment. But the concept of normal is subjective. It's normal for my son to say, Mom, I can't wash the dishes because your dildos are in the sink. You know what I'm saying? That's normal at my house. I'm sure that's not normal at other people's house. So the concept of normal is subjective, and we create our own normal. We are the change. And like Jasmine was saying, having these conversations, but inflecting humor, just like walking around like the sign that James has, just having signs, having t-shirts, having tote bags, things that kind of gets people's brains going to start the conversation for themselves. We don't have to do all the heavy lifting. We can just kind of point people in the right direction. You know what I'm saying? So it doesn't have to be us. It can be something we're wearing. It can be something that we post. It can be something that is, you know what I'm saying? But if we tie it all back, they're gonna say, well, you know, Goody, she's gonna make it about sex. She's gonna make it about education. She's gonna make it about life skills. And that's how you make it normal.
I wanted to like quickly add on, sorry, James, but talking about humor, there was a condom company. I think you guys would probably know like One Condoms. So One Condom, what they did in Malaysia, and I think in Singapore as well, they actually did curry flavored condom or durian flavored condom to sort of, you know, it makes people feel like really weird about all these condoms existing, but it also makes people have a conversation about how funny these sort of condoms flavor exists. But you know, it creates a conversation. That was the whole point, using humor and like weirdness to create this kind of conversation. So I just wanted to add on to that.
I love that you both brought that up. I'm also a big humor person as well. I made my day in the life living with syphilis video, and it was like, it was just meant to be funny. It wasn't meant to go viral. And then of course it did, right? It's like, you know, the more that we make the jokes, and I find, Goody, you're exactly right. And Jasmine, what you were saying too is this idea that when we make the joke or when we bring it up, even if it's the condom company, if it's us, then people have permission to say what's already on their minds. This is on everyone's minds. We're just saying it out loud. And I think that what you said about, you know, everything's about sex and sex is about power, to take that like a step further, I find that to me, we cannot have comprehensive conversations about sex until we're having comprehensive conversations about trauma. Because I think that sex is a lot about communication and connection. And I think that trauma is what gets in the way of our ability to communicate and connect. And so I think that we can't do one without the other, because I mean, I'm sure that if we did an anonymous poll and we said, how many people are nervous to have sex with somebody or to engage in any sort of intimate connection, however you might define intimate connection, then everybody, I would imagine almost everybody would say that they would feel nervous about something happening there, something going wrong, not being able to communicate, not feeling empowered to communicate, not knowing what to communicate, not knowing what kind of connection they're looking for, not knowing if they are conceptually into this because they saw it, you know, on a porn site, or because they're actually into that because they have a fetish or a kink they want to explore, but they don't know how to ask for that because there's shame and because people have been told that we're not allowed to explore and expand our ideas around intimacy and sex, right? So to me, those things go hand in hand. And I can't believe that I'm saying men have this figured out. So please don't take that as the thesis with this. But what I have found in my exploration of having sex with gay men and having sex with straight men, because as a non-binary femme, kind of depending on how I present, I can kind of slide from one pool to the other based off people's perception of me, my attraction to them. And like, you know, I think everybody's hot and deserves to be with whoever they want to. And so maybe that's my ad to be gender fluid. I don't know, try it. There's a bigger pool out there for you. But point being, when I connect with gay men on, say, Grindr, right? Usually the conversation is actually very clear about consent and what they're into and what they're deciding to do. So it's usually like, you know, hey, sup, not much, horny, pics. And then you send a bunch of pics to each other. And then it's like, what are you into? And that's like the fifth question is like, oh, I'm into, and then you name the sexual acts that you're interested in doing. They're usually all the same, but like, nevertheless, you are still setting a template for what you're interested in. You're acknowledging the boundaries of what you're interested in and what you're not. And I think a lot of that is because there's kind of like the who's the top, who's the bottom type of thing going on in the queer community. And because there's limited time, like historically, if you're looking at the way that the queer community has been oppressed for all genders of people that are queer, you had to hide it. So you had very limited interactions with people to be able to figure out if you were a match, right? But I think we can all learn something from that, because by establishing what you're into to begin with, it's very easy to go, oh, I'm not into sexual act A, so we're not a match, but like, you're really cute and I hope you have a great day, right? Or, oh my gosh, I've always wanted to try B. What do you think about it? I'm nervous about blank. Like, that is a lot easier, I think, kind of behind a phone screen, interestingly enough to say. And then when I go talk to straight men, oh my God, they're clueless. Like, just what I have found in my personal vast experience is that they're always like, oh, I just want you to be my queen. And I'm like, I want you to talk to me. I want you to tell me about what you're feeling. Oh, I just want to feel like I'm good. No, Jared. I want you to tell me what you're interested in, what you are actually feeling, right? Everybody wants connection. Everybody not Jared. Yeah, I know, right? Sorry, somebody's ex here is probably named Jared. Fuck him. And so my point with all of this is to say, we're getting so derailed about Jared. I think that everybody is looking for connection, but until we acknowledge that the trauma patriarchy causes everyone and how it disadvantages everyone on different scales and in different ways, but until we acknowledge that this is holding us all down, this has a chokehold on our ability to communicate and to connect, and until we can eradicate some of the trauma that we cause other people inadvertently, then we're not going to be able to have connections and conversations around sex. So yeah, that's my solution. That's all I got.
Can I just add a few more points? And I promise I will be succinct in my answer to the last question. So I'm taking time from my speaking time for the last question. But here I want to talk about the work that I do with children and with parents. And I'm currently writing my first ebook for parents, actually, who are very eager to bring these conversations. They realize that, you know, the 2 hours that I get with their kids is not enough to do the whole education that their kids need for the sexuality development and their well-being. And they want to contribute, they have no idea how. And so there is this idea that talking about sexuality means talking about sexual acts. And actually sexuality intersects with so many dimensions. For example, one question that a lot of 13-year-old boys ask anonymously is, does size count? Does size matter? Again, around the, you know, penis sexuality or penis-centered sexuality. And it's really interesting to know, for example, that in ancient Greece, having a small penis, which you'll see in a lot of statues, you know, in the Greek statues, having a small penis was a virtue because it meant that you were not distracted by the carnal pleasures. And whether we agree with that or not, I particularly find that sad, but that's not the point, because if you can understand that according to culture, according to time, size has a different interpretation and different meaning, then you can take a step back from all the messages that you hear about size nowadays and think, well, this is just today's view on, you know, size. So I think when you start taking sexuality outside of sexual acts and you start thinking of it as, you know, history, psychology, rights, religion, and you start thinking all the things that inform today's perception of sexuality, then all of a sudden you're not so afraid. It doesn't seem so daunting, and it doesn't seem so wrong or risky to talk about your child, to talk with your child about sexuality, because you're talking about all these different topics. And again, as Goody was saying, when we talk about sexuality, especially with health, we're not just talking, again, about acts, but we're also talking about a set of values, right? We're talking about communication. We're talking about responsibility. We're talking about respect. We're talking about so many values. So how about we also invite those values to the conversation, and start making that part of what, you know, sexual health and sexuality is. And then the last thing that I want to say is that sometimes people see the work that I do and they think that being comfortable talking about sexuality has to look like having an Instagram page, having a YouTube channel where you're talking about sexuality, where you know all these things, where you can joke about it, where you can, and it doesn't have to look like that. For some people, you know, sexuality is a private matter, and that's what I tell, you know, the teens that I talk to. Just because sex can happen in, you know, a bedroom and with an intimate setting and not everyone is there, it doesn't mean that sexual health has to be private. You have a body and you are feeling things, even, you know, period pain, period cramps. How many times are we making up excuses not to go to school, not to go to work? Instead of saying my uterus is killing me, we're just saying, oh, I have a cold, or, you know. So inviting all of that into the conversation around sexuality, I think makes it a lot more accessible and easy to have.
Thank you, everyone. Yeah, it ultimately comes down to communication as a fundamental, like, human skill. And if you take sex out of it, it's you need to be able to communicate your own boundaries. You need to be communicating what makes you feel good and what makes you not feel good with other people. So all of you bring up really amazing points. Before we move on to our final question, I would like for our participants to take the opportunity to think about if they have any questions for the open Q&A. We have time for 1 or 2 questions before we end our event. So if you would like to write them in the chat, and I can direct them to our speakers after our final question. This one was directed initially to both Jasmine and Goody, but I feel like all of you are going to have some really great points for this regardless of where you guys come from. But what are some ways that healthcare providers can incorporate trauma-informed and gender-inclusive principles when discussing sexual health or providing sexual health care?
Okay, so I spoke to this a little bit earlier about ungendering our language. And when I say I do professional development, I love that we're talking about the holes in healthcare, because I specifically support educators, social workers, and healthcare providers around sex, gender, and equity, because it's missing, right? There is a dearth when it comes to supporting transmasculine pregnant people. The language that we use around pregnancy is all women and mother and all of these things. And I also, when I say, you know, if I'm on a live or something and I say people that get pregnant, they say, oh, you're minimizing womanhood. No, I'm not. You're trying to gatekeep womanhood. What I'm doing is reminding society that women are also people. Yeah. So if we step back in our, especially in health spaces, and refer to the genitals that we're talking about, refer to the body parts that we're talking about, refer to the sexual acts that we're talking about, and remove the human behavior from it, it does become more trauma informed, because you are directly reducing micro and macroaggressions for the patient in front of you. You are talking specifically about what you need to address to help their medical care, as opposed to the judgment that you may or may not be aware that you have in your implicit bias around the behaviors as you perceive as whatever. So specifically educators, social workers, and healthcare providers, because we are frontline helping professionals. I have a master's of social work and a master's of public health, and I saw so many holes in that training around supporting gender equity. And what happens is you're humanizing the person in front of you. You're humanizing the group of people that you want to help, or groups of people, your priority populations. And so by ungendering the language and thinking about the ways that you can remove male, female, man, and woman from the language that you're using, be it in your copy, your emails, your conversation, the way you support folks, all of that helps open up more people to hear your message and see you and be supported and helped by you. But it also, again, reduces that trauma. It helps you become more trauma informed, because you're not perpetuating more trauma onto people. And it also can help create a safer space for the people in front of you to help them open up and express maybe some traumatic things to you, or express ways that they've been harmed by other individuals, so that you can also support them. When I talk to healthcare professionals, I've taught at Johns Hopkins and UCLA and places like that, because there are white coats getting their med degrees now that believe that the level of melanin in your skin impacts the way you perceive pain. Still. And some of them are Black. It's like, you got melanin, fam. Do you experience pain differently? You know what I'm saying? So there are only like 2 or 3 books that include the clitoris, medical books that include the clitoris, right? So when we talk about harm reduction perspective and trauma-informed care, those are the buzzwords and search terms and keywords and SEO that everyone is about right now. But when you ungender your language, even if you just do it professionally and at home you still man, woman, you know, boy, girl, it helps you become a more trauma-informed professional by default. And it's an easy way It's a low hanging fruit, as the business people like to say, because my bachelor's is in business. It's low hanging fruit, right? In an easy, accessible way for you to shift the impact of your work, your practice. All of y'all on here, I see healthcare professionals and stuff like that. All of that. It's an easy, low hanging fruit way to just improve the way that you impact the communities you serve.
Jasmine, did you want to say something? Because I didn't want to jump in until you had a chance to speak.
No, you can go first.
I just taking what Goody said and running with that. I think that trauma-informed care, and this is coming from the lens of I'm a trauma-informed yoga teacher, and I don't talk about that a lot because I stepped away from that space because it's very difficult to support the white institutions without culturally appropriating yoga. So point being that this teaching comes very specifically from South Asian communities, not from somebody like me. And I think that what I have learned is that everybody has trauma. And so every single person that sits in a patient chair is going to be traumatized in some way. And oftentimes we don't want to tell you how. And so trauma oftentimes comes from situations where people are disempowered in some way, shape, or form, and are seeking opportunities to exert their autonomy over their body. And so that's, I mean, there are many ways in which we can look at trauma, but I'm thinking specifically in the medical field, that is a very common way. And that is also my personal experience. And so what I find the kind of disconnect is, the gap is that people want to just use the right pronouns and say that that's that, or they want to just, you know, say the right name, or they want to just make sure that they didn't weigh you because you're somebody who survived an eating disorder, something like that. And they think that's enough, as opposed to actually offering you opportunities to exert your bodily autonomy in the medical field, which can be a very disempowering place in which to try to ask for care. And it's very vulnerable. And it, for many of us, myself included, feels like a very unsafe place to air very personal, vulnerable things with essentially someone who is a stranger. You know, like if you have somebody who's been your individual medical provider for a long period of time, you're in the minority of people, because that's not often how it works, especially in the US healthcare system. And I think looking at the political zeitgeist right now and how bodily autonomy is consistently on the political ping pong table right now, regardless of your identity, we have over 500 anti-trans bills that are trying to legislate autonomy away from transgender people. We're looking at the overturning of Roe v. Wade and the ramifications of that. We're looking at mifepristone right now with the lawsuit that's in Texas, and how that is hanging in the balance, and how our Supreme Court has decided that people do not deserve bodily autonomy. So in that one space in the medical profession, if you're a provider, if you have any access to it in any way, what are the ways in which you can actively combat that? What are the ways in which you can give someone as much autonomy over their experience in your space as possible? And so I think it comes from reminding ourselves that everyone is traumatized, and not that we want to go around thinking from it, because it sounds like a very negative space, but I think it comes from a very caring space to go, the next person who's walking into my office is incredibly traumatized, and I have the opportunity to offer them as safe a space as possible. But you can't sanction the safe space. You can only offer opportunities for them to take charge of their bodily autonomy, and then they can interpret that as a safe space or not. I think that we often give ourselves too much credit for how much we can do to make a safe space. And in my experience, it's actually backing up and saying, how can I be of service to you? Do you feel comfortable telling me what the issues are that you're facing? Don't tell me how to fix it. Ask me what's in my way, and then can we work together to find the solution? I think that that reframe is something that I found in like physical yoga practice, that also like in working with people, and I'm thinking from like domestic violence shelters, from trauma survivors, things like that. I think that bringing that, and consent, exactly, Tori, just as you're saying, consent in the doctor's office, collaborative care, exactly. Those are the things that are missing, that can't necessarily be taught from a textbook, not only because the textbooks are so flawed, but because those are interpersonal things. Back to communication and connection. Everybody wants to be able to communicate and connect. What are the ways in which you can open yourself up for people to do that with you? It's only you know the answer to that, you know?
I'm taking in so much from everything that everyone is saying that I forget that I also can chime in, and some of the points that I had in my mind just like go because I'm fully actively listening to y'all. I think from my experience, as you were saying, James, a lot of people come in and they're traumatized, and I think going back to specifically the STI diagnosis and the receiving an STI diagnosis, the first time we hear that we are positive for something is from a doctor. And that the way that this is communicated, or the way that the doctor will respond to our reaction to this news, can be even more traumatizing. And so I think being aware that this is a very delicate space, not to put fear in you all and saying you have, you know, a loaded gun in your hand, looking at someone who is very vulnerable in front of you. But I think something that I have found that from a lot of people who talk to me that is not very effective is to keep this medical gaze, this distance between I am the doctor and this is the patient, and treating, like talking medical jargon and talking, you know, treating the person as a case and a patient versus a human being who right now is emotionally impacted by the news that you have just given to them. And so I think, you know, if I was saying earlier, doctors are not trained to talk about these things, but if we forget for a second that, you know, we're doctors, we're patients, we're all human, and we can all imagine what it feels like to receive a news that at the end of the day, James, again, you were saying this, who cares if you have chlamydia? Like, it shouldn't be a big deal, but because we have loaded so much meaning into STIs, all of a sudden I feel like my identity is hurt from this news, and that my worth is hurt from this news. And I think nowadays there's so many, thank God for social media, not for a lot of things, but for this, there's so many people who are, you know, talking about their experience, offering resources, coming up with really helpful tools who are accessible to people. And I think if doctors could perhaps spend a little bit of time researching who are these people, you know, advocating for sexual health in positive ways, and who are showing what it looks like. Again, I'm speaking about this STI diagnosis case specifically, what it's like to live with an STI and how that doesn't have to mean anything unless you make it mean something. Because yeah, people are going to feel alone, and they're not necessarily going to feel empowered to talk about it with people around them. And so giving them that sense of community, even if it's through a screen and it's with people they don't know, is still going to, you know, push them forward by, you know, I don't know how many years, because they're going to see representation of, oh, this is someone who also have what I have, and they look normal, they look like they have a normal life, they have friends, they have family, they have a partner, they have a dog, they go on vacation, they go on a restaurant, like they have a normal life. And all of a sudden, just knowing that, just seeing that alleviates so much pressure. So again, it doesn't have to be, it goes further than the doctor saying you're going to be fine. A lot of people have this, just sharing the people who are doing this work and letting them see that and come to that realization will go a long way.
Yeah, I was listening to everyone's thing. I was trying to think of what to say, and as everyone was sharing, one of the things that I thought about was in Malaysia, because the stigma around sex, around pleasure, around STI, especially STI and sex, and this narrative of like you can only have sex if you are married. There's a lot of issue of especially women coming into clinics getting STI testing or getting IUD and all that stuff. It's really hard for them to get it because they're always like, oh, do you have the consent of your husband? It's always within the consent. So if you're like a single person and then you want to get it, if you're unmarried, you can't get it in government hospitals. Even though Malaysia, actually, surprisingly, interestingly, Malaysia has one of the best healthcare system in Asia. But because of all the stigma and all this like taboo and stuff like that, it's really hard to get certain things, especially related to sex. I recently had a friend who found out that she has HPV, and the first thing that the doctor said was, oh, this is what happens if you don't do it the traditional way, because she's unmarried. And so like, it was such a traumatic experience for her. And when she got her results, and they said like, hey, we got your results, come into the clinic and get your results. She's like, okay, am I positive? What's the results? And they're like, I can't disclose. Come in like 3 days when the doctor is in. And she's like, keep pushing, can I get the results? And still they're like, no, come. So she waited for 3 days and she was traumatized. And once she comes in, this is the kind of response that she gets. This is what happens if you don't do it the traditional way. So with regards to Malaysia, there's still a lot of like this, the stigma around sex, the stigma around being not married and having sex, which is something very, very normal. Malaysia, especially, like, dude, we have Tinder, we have all these different apps and stuff like that. You can just have casual, you know, and all that stuff. But still, I feel like sometimes we're living in this bubble of like, you must be married in order to have sex. So fortunately, there are a lot of organizations out there who are actually advocating for like inclusive healthcare providing to everybody. And also like clinics and all that stuff. Unfortunately, it's very inaccessible in the sense where it's quite expensive because it is private. So you do have to pay like very expensive, like 400 ringgit for a comprehensive like STI screening, which is roughly about 100 USD. But imagine 400 USD if you're getting that amount of money, you know, in the US. So 400 ringgit is really a lot of money versus it's kind of like free in government hospitals. And I think you only have to pay one ringgit or something. Yeah. So it's very, very tough. So a lot of education needs to be done in Malaysia, a lot of also understanding the law, because safe abortion is actually legal in Malaysia, but a lot of healthcare providers don't know that and they don't want to offer that service as well. And that's problematic here, but yeah.
You all have given me so much to think about as someone who works within the Western healthcare system. I feel like I have a lot to reflect on. And as someone who is kind of confined by the policy of the government and the healthcare system, but also is really working to kind of practice with an intersectional kind of healthcare focus, I feel like I'm going to take away a lot from today. So I really thank you all for your thoughts and everything that you talked about. It doesn't really seem like there were any questions, but I would love to invite everybody who's participating and has attended today, just write something in the chat that they loved well, or has really particularly stood out to them, or something that they're going to look into as we kind of wrap up the end of our event. Okay. The last couple of things that we have today is just talking about how Medical Herstory is thrilled to announce that we've been nominated for a National Diversity Award in the UK. We're truly honored to have been nominated for the Community Organization Award for Gender, an award that applauds groups, charities, and voluntary organizations that have made an outstanding contribution to their local community or nationwide with their diversity as their core focus. If you enjoyed today's events and feel inspired by Medical Herstory's mission to eliminate sexism, shame, and stigma from healthcare experiences, we'd be incredibly grateful if you'd vote for us to win this prestigious award. Voting closes on May 12th, and you can find more details on Medical Herstory's Instagram account, but we'll also share a link to voting, the voting website in the chat. Thank you so much. We'll also be sharing a feedback form so you can tell us how we did today and what you'd like to see changed or kept for the future. And again, I'd really like to thank Jasmine, Lorene, James, and Goody for sharing their knowledge, their experience, and their expertise in such an important topic that I'm passionate about, and clearly everyone who attended here today is also very passionate about. So thank you and have a great day.